Come on now. Aretha Franklin started things off. A natural woman here on Kaya 959. We're talking all things women's health today. It is the final Wednesday of the month. We bring in a special guest, and today we're bringing in Dr. Palesa Pule. Hello.
Good afternoon.
How are you feeling?
I am fabulous. How are you?
I'm wonderful, man. It really is an honor to have you here. And I think being that it is the month that it is, it's Breast Cancer Awareness Month, we thought, let's bring in an expert so that we can actually get proper information as to how it is that we can take better care of ourselves, how to get the signs and the alarm bells going regarding our bodies, and just to be a little bit more in tune, and also when to know when to come to see you, because that's also another thing as well. I want to start from the beginning. Who is Dr. Palesa Pule? Where do you come from, and how did you get to the journey of now getting into OBGYN?
Okay.
Yeah.
So I'm a mother. I'm a wife. I'm a daughter. I'm a sister. I'm a rakhadi.
Oh.
And a friend.
Yeah.
And a gynecologist. So I was born and bred in the Vaal. I grew up in Sebokeng. Attended primary school in the Vaal Triangle. I moved to boarding school, high school. I went to Potchefstroom High School for girls. Thereafter, when I completed my matric, I went to study engineering in Cape Town. There I was, the golden child of Anglo Gold at that point. I had a bursary from Anglo Gold.
Oh, wow.
Went to UCT to study engineering. But very quickly I realized that this is not me. So within the first 6 months, I actually spent the last 6 months of the year traveling the Cape and not really studying. Much to my parents' horror, came back end of the year, hadn't done so well, and I had some SAPs, and started my medicine journey the following year. Went to Pretoria University, Tuks, and the rest is history. I finished my undergrad degree in 2005, and I went on to specialize at Wits University. I qualified as an obstetrician-gynecologist in 2012. And in 2013, I moved to private practice, and I've been in private practice since then. It's almost 13 years.
Sure. How often do we as women need to visit a gynecologist? And also, what age do you think we should start seeing you guys?
Okay. So I would say from when a girl starts her periods.
Oh, really?
They should see a gynecologist as early as that. So for most girls, it's going to be between the ages of about 9 to 13. I think more than anything, for us to zoom in and see, are you having proper periods? Is this normal? To give information, also to make sure that we are doing the right things. When I say doing the right things, I'm talking about things like try as much as possible to avoid putting young girls on contraceptives and that. So if you can give understanding to a young girl and her parents as to why certain things are happening, you put them at ease and you explain to them that there's no need for certain interventions that we usually, sometimes would prescribe. So I would say that. And then obviously from the age of 18, a young girl is going off to university, to tertiary. You need to start having conversations around contraceptives, around intimacy, obviously also at a young age. And I like what government is doing now. We are vaccinating young girls against human papillomavirus, HPV. So if we miss that 9 to 11 window period, then at the age of 18, just before they go off to varsity, it's also an opportunity to start having the conversation, vaccinating them before they go off and become intimate and possibly are infected with the virus, HPV.
Yeah. What are some important things that we sometimes miss in terms of the alarm bells in our own body that we miss to the point where we come to see you, Dr. Boule, and sometimes it's not, I wouldn't say it's too late, but we're already far in when it comes to whatever diagnosis, if you will?
I think we have this misnomer of assuming that, well, that's just how I am.
Yeah.
So a lot of women will say, I have very heavy periods that keep me away from school, or very heavy periods that, cause me to have to be transfused. But that's just how I am, And also my mom was like that and all of that. Your body is always talking. Your body is talking to you all the time. And we know our bodies, and when something is not right, act on it. Act on it. So I think that, that is a one downfall mistake we make as ladies.
I think from a practice perspective, I think a lot of people always have this question: why is it that when we go to see a gynecologist, we have to pay for it cash and then claim via medical aid? What is that about specifically? Because most of the time, that's happened to me most of the time,
Not necessarily. It's not all specialists. So remember, when you look at private practice and specialists, medical aids will determine how much they will pay for a certain procedure, consultation, or interaction with a doctor. And we may not necessarily agree that is how much this consultation should cost. I mean, if someone is going to spend 30 minutes with you and your medical aid says to you, only charge this person 500 rands, and it's your expertise. Remember, also as a specialist, you are the expert. The buck stops with you. So you need to make sure that whatever information, whatever management you give to this patient is going to work, and it really is where the buck stops. So we don't always agree with medical aids.
Okay.
And no, Andy, not all specialists are working that way. No. So you get different ways in which specialists work.
Okay. I wanted to have a conversation about discharge, and funny enough, Aurora, you sent a voice note regarding discharge, because a lot of the discharge conversation happens when girls hit puberty and they're like, what's happening here? What's happening here? So I want to play this voice note and then we can have a conversation regarding discharge.
I have a problem. I have a discharge that I've had. I'm not even sexually active, because I know obviously it's the imbalance of the bacteria. But I've taken antibiotics. I've used the over-the-counter medication, but it's just not clearing up. So I don't know what to do anymore.
So is discharge normal? When is it an alarm bell? Is it a smell thing? Is it a texture thing? How do we know that we need to see somebody regarding discharge?
Okay. So in the vagina, you've got bacteria that normally live there. Just like you have in your gut, in your stomach, you've got bacteria that live there. And the bacteria that live in the vagina, the most dominant one, we call it lactobacillus. And it's going to give you a pH of between 3.5 and 4.5. So very, very acidic. If you think of a soap like Dove, for instance, Dove has a pH of 7. Okay, so a lot of ladies will say, but I'm washing with Dove, I'm washing with Sunlight, I'm washing with Dettol. Now you can imagine, if the pH does not match, you are going to disturb those flora. So we call them the normal flora that live in the vagina. So in the vagina, because we've got estrogen, we've got progesterone in the body, normally as women, you have to have a discharge. It's normal. And it's going to give you a slightly fishy smell, and it should not be itching, it should not be green, and it should not be copious unless if you are pregnant. So a discharge is normal in the vagina. It is only when we start disturbing the flora, this is when we're washing with soap, this is when we're taking antibiotics, this is when we're taking bubble baths, that we are going to disturb the flora. Then we're going to get overgrowth of one of those flora that live there. So, and the most common ones would be thrush, candida. Another one would be bacteria vaginosis, which would give you an extremely fishy smell, a bubbly, grayish, off grayish discharge, which is quite offensive.
So then what do we use other than water, girl? You got to tell me something. Can I use pure soap? Because there's that pure soap that's just regular glycerin soap. Is that safe to use?
You can use clear soap. You can use plain water. You can use plain water. You can use a soap that is specifically for that area. And we've got a few on the market. Okay. If you had to walk into, your disc games and that, and you go and you'll see that, I just don't want to mention brands, you'll see that there are soaps specifically for that area. So sometimes, and you find that if you've washed the soap, you start finding that your discharge is changing a little bit. And I always say to my patients, you didn't need me. You could take something as simple as a probiotic to try and balance those bacteria, the flora. And 90% of the time, it sorts out the problem. 90% of the time.
Sure. All right, we want to take more of your questions. Please send them through 063-688-0959. Dr. Palesa Pule is in the building. It's Janet Jackson. That's the way love goes on Kaya 959. It's a special edition of Girl Let's Talk with Dr. Palesa Pule. She is an OBGYN just for you, and she's literally here for the entire hour to chat about women's health. Got a couple of questions, okay? Lebohang sent me a message talking about, can you please touch on perimenopause? What is it? How does it differ from menopause, and when it starts, and what are the symptoms of perimenopause?
Okay. So perimenopause, it's that transitional period between your reproductive years and the menopause. So typically happens between the ages of about 40 to 44, can happen slightly earlier in your late 30s, and happens because you've got a decreasing amount of eggs in your ovaries and therefore estrogen. Okay. So you are still having periods. They may be irregular. So what are the symptoms? Symptoms are usually brain fog, memory loss.
Complete memory loss?
Not complete. Memory loss.
Okay.
Insomnia.
Hey.
Depression, anxiety. Mood swings. You may have bone and muscle pain. Bloatedness, vaginal dryness, painful intercourse.
Sure. And there's nothing we can do to prevent this. Is there a pill? What? I'm not trying to get there. And then what's the big difference between perimenopause and actual menopause?
Okay. So perimenopause, it literally can take anything between 4 to 6 years before your periods completely stop. So you are still seeing periods. Your periods are just irregular.
I see.
Irregular could be they much decreased or they much heavier. So remember, we still have eggs at this point. They're just not as much as they were. So when a woman is born, or when a girl child is born, you're born with about 2 million eggs. This is now age 0. By the time that you get to your ages of 40 and above, you've lost 90% of those. Your eggs produce estrogen, which is the dominant female hormone, as well as progesterone, which is the other female hormone. So with menopause, we define it as a period of 6 months of no periods whatsoever. So once your periods have disappeared for 6 months or more, they are not allowed to come back.
I'm with you. I got another message here saying that, Dr. Palesa, what is the cause of cysts? Because there's a pain of cysts that is killing me, specifically when I'm on my periods. I experience a particular pain. I'm not sure where the cyst is, but maybe we can touch on it when there's a cyst in the ovary, because I know sometimes that's PCOS, and what that is, and of course where there's cysts, maybe, and other places.
So I don't like the word cyst because it's such a misnomer, and it always makes ladies feel like something is wrong. So remember, we just said that when a girl child is born, you're born with about 2 million eggs. When puberty begins, which is between the ages of 9 and 13, you've got about 500,000 eggs left. Every month, you need to mature an egg. Although you also lose quite a lot in a cycle, you need to mature an egg every month and release it, ovulate, And this egg will go on to be made by a sperm and someone falls pregnant. If they don't fall pregnant, it comes out with menstrual blood. So at the beginning of a cycle, you are maturing this egg in what we call a follicle or a cyst. So when you say cyst, it's almost as though it is abnormal. The only time that it becomes abnormal is if we get to, so day 14 is when most ladies would ovulate. If we get to day 14 and this egg has no, this follicle, which is a balloon that surrounds the egg, has not popped open. And then you have persistence of this follicle or cyst. That is when we would say it's a cyst. And a cyst generally would give us irregular periods, would give us low abdominal pain, back pain, and also obviously a delay in our menstrual period. So we would then need to find out, why have you not ovulated? What are the underlying issues there? Could you have polycystic ovarian syndrome, like you said? Are you on a contraceptive, like your pill? So your pill, what it does, it makes your ovaries sleep. So with the pill, you don't ovulate. You shouldn't ovulate. And that's how it works as a contraceptive. So we would need to know what are the causes and, you know, how big is it? So we look at, and also, whether a cyst gets removed or not depends on the size. You know, so we don't always remove all cysts. So we look at the size, we say, okay, how can we support this phase of your cycle? Can we put you on an oral contraceptive to try and avoid it from growing? Remember, we said combined oral contraceptives are going to make your ovaries sleep. So can we put you on oral contraceptive to try and avoid it from getting too big? Or is it already too big? Does it need to be surgically removed?
Sure. Let's touch on PCOS and what that is and what are the key symptoms of it, because I know it's a cocktail of things. So let's touch on that.
Okay. So PCOS, or polycystic ovarian syndrome, it's a very complex metabolic condition. And I say complex because there's a number of symptoms. Most common are irregular periods, symptoms of an excess of androgen production, androgen or what we say a male hormone production. So it would give us, so male hormone production would give us acne, would give us male hair distribution pattern
on the beard as well,
on the face, on the chest, on the abdomen, on the legs. It would give us male distribution of balding. So in a lady, you would have balding or hair loss. Balding, it would give us that. It would give us infertility. And sometimes in about 60 to 80% of patients, it can give us insulin resistance. Okay. So there is a classification system or criteria that there was a consensus. So a lot of medical boards sat down and came up with what we call the Rotterdam criteria of diagnosing PCOS. Another thing I forgot to mention is weight gain, especially around the tummy. And that's why I say it's complex. So the criteria only talks about three things, three criteria, and you only need two of those to say that chances are you've got PCOS. The first one is evidence, clinical and also blood-wise, biochemical, that you are not ovulating or you're ovulating minimally. So we would then look at your periods. So periods, in this criteria, your periods are generally, the cycles are more than 35 days and more apart. So already you know something is not right. When from the one cycle to the next, it's 35 or more. It would be if you are seeing less than 8 periods in a year. So that's one criteria. Second criteria, we come back again to symptoms of excessive androgen production. So your acne and all of that, your acne, your male distribution, your balding, and also when we do bloods, we look at your testosterone, we look at other hormones called your DHEA, and all of that. And if they are positive, that's also another criteria. And then lastly, multiple cysts on the ovary. So multiple cysts can be ovary that has more than 20 follicles on both sides, or where the size of your ovary is more than 10 cubic centimeters. And so if you look at that, you can see that I mentioned nothing about the weight gain. I mentioned nothing about fertility, also, although fertility will come on into ovulation. So it's complex in that not everything is taken into consideration. Okay. So that's how you would diagnose it. And you can imagine the mental as well as the psychological and emotional complexities that go with a diagnosis like that, especially in young girls. Okay. So management would be individualized. So we look at, remember we said only 60 to 80% have insulin resistance. So we look at your age, we look at your fertility needs, we look at whether you've got insulin resistance or not. So say a young girl came and we have made the diagnosis of PCOS just based on one or two of those three criterias, but there's no insulin resistance. What we want to do is we want to regulate her periods so she has more regular, frequent periods like the rest of her friends. We would put her on a low dose combined oral contraceptive, and what it does, it would mimic your cycle and make you think that you're actually having normal periods when you're not. If, however, someone comes to me, they're in their reproductive years and they say, I'm trying to fall pregnant, obviously a combined oral contraceptive is not the way to go, and say they don't have insulin resistance, we then want to induce ovulation. We want to improve sensitivity to ovulation. We put on supplements, we put on medication to induce ovulation. And then say now we've got someone with insulin resistance and or also an excessive amount of your male hormone. So we would need to send someone to an endocrinologist. We need to manage that excessive amount of production of the male hormone. Also, with recent developments with insulin resistance, we've had things like your semaglutides, your Ozempics, your Mounjaros that are helping us improve insulin sensitivity, aid with the weight loss, and also we see how it improves the ovarian function. So a lot of ladies then end up ovulating just because we've put them on a semaglutide.
Very fascinating.
So quite complex, and dare I say, it's not a condition that should only be managed by a gynecologist. So we bring in our endocrinologist, we bring in our dietitians in the supplementation is also very important, and just education. As a whole. But the earlier it's diagnosed, the better, especially for fertility, and also to prevent a lady from going on and developing diabetes in the long run, because from insulin resistance and the metabolic syndrome that we get, we know that you're going to then go on to develop diabetes mellitus.
Of course. Sure. Lots of information. I hope you're taking down notes. More from Dr. Pule in a bit. It's TLC with Unpretty on Kaya 959. We've got special guest Dr. Palesa Pule. We're talking women's health. All of your questions right now. I want to start with you. What question do you have for Dr. Palesa?
There's a question I want to ask a doctor. I once had an ectopic pregnancy. I think it was 2021, if I'm not mistaken. So now I'm trying to have a baby again. I'm really struggling. I've tried several doctors, but still it's failing. Please help.
Sure. I can imagine the type of fear that comes with that as well. Over to you, doctor.
So infertility is such a heartbreaking topic. And more, we're seeing it. About 25% of ladies will struggle to conceive in their lives. So there are 4 things that we need in order for us to fall pregnant. And I always say 3 of them come from the lady and 1 of them comes from your partner. So the first thing we need is for a lady to ovulate. Ovulation means you release an egg. How do you know that you are ovulating? You have periods that are predictable. So you can say to me, I know that I'm ovulating because I know around the 15th of every month or the 16th, I'm going to see a period. The chances are you are ovulating. The second thing that we need is we need normal, healthy fallopian tubes. Tubal factors play a big role in infertility. What would give us problems with the tubes? A previous pelvic infection. So pelvic infections love your tubes. And tubes are like your brain cells to a certain extent. They are very difficult to revive. Once damaged, it's very difficult to revive them. That's the second thing. Third thing that we need is a normal healthy sperm that looks like a tadpole, has genetic material in the head, swims in an upward fashion. Together, the egg that's been released by your ovaries and the sperm are going to meet each other in the tubes. So you can imagine that if the tube is damaged, there's no way for them to meet.
Sure.
And this is actually where IVF comes in, because IVF just basically takes over the function of the tube. And then lastly, we need a normal healthy uterus without any fibroids. If there are fibroids, they should not be sitting in a place where a pregnancy may want to implant. And those are the 4 things that we need. We know that when someone's had an ectopic pregnancy, tubal factors or abnormal tubes are at the top of the list. And what happens on one side of the body also may happen on the other side. So chances are the other tube may also be damaged.
Sure.
So I suspect that this might be what is going on. So what our listener needs to do is they need to be seen by a gynecologist. We need to check, or any gynecologist, they need to check tubal patency. There are 2 ways of checking your tubes. The first one is laparoscopically, where we do a minimally invasive procedure and we check your tubes. Or the second one, we do what we call an HSG, hysterosalpingogram. It's done usually by X-ray departments. We pass a dye through the cervix and we see the dye coming down, and we take X-rays as the dye comes down. So I suspect that there may be abnormality of the other tube or occlusion of the other tube.
Is there anything that we can do diet-wise or maybe lifestyle-wise to get our bodies ready when it comes to, childbirth, and to make sure that the uterus is ready, the eggs are ready, all the girls are in formation?
So I like the fact that you mentioned diet, Andy, because diet plays such a huge role. We were just talking off air, and I was saying to you, 3 out of 5 patients that I see have PCOS. So remember, when we looked at the criteria for PCOS, we spoke about an ovulation or not ovulating, not releasing an egg. If there is no egg, a sperm is going to get to the tubes and there's nothing to fertilize, and it will just go back and go out.
Sure.
So diet plays a big role. We know that carbohydrates play a big role. A diet that's high in processed food play a big role.
Sure.
So we should be looking at a diet that's low in carbs. We need a diet that's high in antioxidants. We can also look at supplements like your inositol, your folic acid, which aid our ovulation and also assists with improving insulin, or at least increasing your insulin sensitivity that we usually get in your PCOS. So diet.
Okay.
I cannot stress that enough.
Okay, here's another one from Busisiwe.
I have been experiencing severe pains. It started off my experience just before my periods and during my periods, which is something I've never experienced before. And to my surprise, these pains, they come and go even when I'm not on my periods. That's the first one. The second one, my periods have reduced. The number of days I go for my periods have reduced drastically. Like I used to go for my periods for 5 to 6 days, and now it's only 2 days. Next, it would be the first day, the second day, the last day is just your drops, sometimes nothing. So I don't know if I should be concerned. And I'm 38, so I don't know if it has to do with age as well.
Cause and concern?
Okay, so there's a condition that we call endometriosis, which is what we call a pain syndrome or pain condition. So endometriosis is a condition where the lining of the uterus that we call the endometrium grows at sites outside of the uterus. So the lining is called the endometrium. When it grows outside the uterus, we call it endometriosis. Endometriosis happens when we have an excessive amount of blood during your periods going through the fallopian tubes and depositing outside of the uterus, usually in the pelvis. Typically, it's going to give us painful periods, pain that starts before your periods, a couple of days before your periods. The pain is there with your periods, just that it's worse. Heavy periods, painful intercourse, difficulty conceiving, constipation. So the type of symptom would also talk to the staging. So we've got 4 stages, 1 to 4. By the time that we get to stage 4, everything in the pelvis is stuck together. So your uterus is stuck to the rectum at the back, and this would give us painful intercourse. This would give us constipation because your peristaltic movements are not as efficient as they would otherwise be if the rectum is stuck to the uterus at the back. And this is a debilitating condition that gets worse and worse and worse.
Sure.
If we go back and we think about what we said about your eggs declining with age, and your eggs producing estrogen, which builds the lining of the uterus together with the progestogen, the older you get, the less heavy your periods are supposed to get. So if your periods are getting heavier with age, there's a problem.
So please go see Dr. Boule.
There's a problem.
Please. Here's another question.
Hi, Dr. Boule. I'm diagnosed with endometriosis. I'm for a 2-year-old woman. But now what's happening recently is I'm having like a delayed period. I'll be on my period, but it's processing slow. I don't know if it's a normal thing, but it's something that's been happening. I don't know if I'm going towards my menopause or it's just a normal thing. So I go on my periods for like 3 days or so, but it will be like a period that in a day I would see it maybe a few hours, then it goes away, but it's very, very painful.
Okay. So it sounds like a combination of endometriosis. She mentions pain.
Yeah.
So what gives us period pains are contractions of the uterus. The thicker the lining of the uterus, the more the uterus needs to shed, the heavier the period. To get that blood out of the uterus, we need to contract that uterus. Okay. So if there isn't much blood in the uterus and yet we are experiencing painful periods, there is a problem because we're not shedding that much. Why are we getting these severe contractions of the uterus? Because remember, it contracts to get the blood out, but there's no blood to contract out. So endometriosis, remember we said it's a pain syndrome. It's going to give you this excessive period pains that does not necessarily always match with the amount of blood that we see.
Yeah.
But also our listener mentions that she is over the age of 40. So also, the perimenopause may be coming in. We mentioned that our periods become irregular in the perimenopause, and irregularity could be they're little now or they're heavy. So in your case, it sounds like they are little. So it sounds like a combination of the
both.
two.
Sure. One last question.
Hi, doctor. My question would be about a pap smear. How important is it to have a pap smear or to get a pap smear, especially after pregnancy?
And also how regular. But
Okay.
continue, yes.
So pap smears, smears that we take on the mouth of the womb. The reason we do pap smears is because cancer of the mouth of the womb, cervical cancer, that's the gynecological cancer that's likely to kill any woman between the ages of 16 and 45.
Sure.
And sexually active. I say sexually active because there's a virus that we call human papilloma virus,
HPV.
which is a sexually transmitted virus. Like any virus, once you get infected with a virus, it stays dormant in your body and you don't know about it. So we can never get rid of a viral infection at all in our body. So it will lie dormant, it will sleep, it will be reactivated and that. So when we do pap smears, what we are trying to do is we're trying to see, have you been infected with HPV, number one? And this is why with a pap smear, we also do an HPV subtyping. Have you been infected with HPV virus? And has it started giving us effects on the mouth of the womb? Okay, so there's a spectrum of abnormalities. So we will start off with mild changes on the mouth of the womb, with moderate changes, and up to a cervical cancer. So once someone is sexually active, they must be having a pap smear. They must be doing a pap smear. You don't need a pap smear if you've never been sexually active. So we sometimes get young girls who come and they say, I've been told to have a pap smear. And you say, have you ever been sexually active? No. You don't need a pap smear. You're not sexually active. So what is the frequency? So this is where, we differ. Private and public, we differ. So public sector says you will do your first pap smear at the age of 25. And you will continue doing pap smears. Once you have 3 annual pap smears that are normal, you can stop and then do one at the age of 50. But in private practice, we do an annual pap smear, because you can go from a normal pap smear this year and next year we have an abnormal pap smear. And what are the triggers, or what is it that would cause that? Remember, we said HPV or any viral infection will lie dormant in your body. So I see you now, everything is fine. Excessive stress happens in your body. We get reactivation of this HPV. When I see you next year, we've got changes on the cervix. So the 3 things that would usually reactivate this HPV is it's excessive stress, could be physical, emotional, a recent pregnancy, as well as the presence of a chronic illness. We know that the HIV virus fuels the HP virus, In the presence of the HIV virus, HPV just multiplies and multiplies.
Yeah.
So we should be doing an annual pap smear.
Oh, she is indeed live. We've literally got a few more seconds with her, but I want to take your voice notes. I want to take your questions. Itumeleng.
Good afternoon. My question is really just about fibroids and whether or not the use of castor oil, just rubbing it on your lower abdomen or pouring it into the belly, if that really helps, because I've been found to have fibroids. I found that out a year ago when I went to my gynae. And so I just wanted to know if there are other herbal treatments that I can utilize instead of, undergoing surgery. So yeah, I just wanted to know about that. I'd appreciate it.
I've heard about this too, Itumeleng. Is this an effective method?
So let's talk about fibroids. Fibroids are tumors that we get in the muscle layer of the uterus. In medicine, everything that we do is guided by evidence. So we talk about evidence-based medicine. Okay. So speculations or postulations as to what causes fibroids: a diet that's high in carbs, excessive estrogen, sometimes in the form of your contraceptives that you're on, can give us fibroids. I've never come across any evidence talking about castor oil. I've never heard about it. I know a lot of people talk about traditional medicine and all of that, and I personally have not seen it, and we don't have it as part of our evidence-based medicine. So my advice would be dietary changes, decrease your carb intake, and also, as much as possible, let's try and stay away from things like your combined oral contraceptives. Maybe change the type of contraception that you're on so that it's not estrogen based, so that we're not causing proliferation and growth of this fibroid. We've got modalities other than surgery, of managing fibroids, such as your uterine artery embolization, where we shrink the fibroid. So surgery is not the only way. So we've got non-surgical interventions also.
Okay. We're going to be late for news. Sorry, Gladys. It was about strong. But I want to play this last note. This is specifically for you. It's from Refilwe. Take a listen.
For me, it's not a question. It's an acknowledgement that I want to make to Dr. Palesa Pule. I had 4 sessions with her. 4 as in because it's 4 kids. But the first one was a miscarriage. Palesa Pule held my hand throughout the process. Palesa Pule ensured that my kids were born, and they were born alive. What I love about her is that she would always say, these are not your kids. Until I hand over your child to you, this is not your child. I absolutely appreciate Dr. Palesa Pule, and in all honesty, if anybody needs a proper gynae, Palesa Pule is the person that I would recommend. In me saying I would recommend is because I'm looking at the team that she works with. She ensures that she works with the best team ever. Hence, I always ensure that on my birthday, 15th of January, every year, I would take a cake to them. I gave birth to my kids 2018, 2019, 2021, and she was always there for me. So, Mepule, kia leboha. This is Refilwe Mtwache.
Wow, thank you, Refilwe. By the way, where can we find you? Where can we get a hold of you? Give us those details, and also where's your practice as well?
So my practice is in Kempton Park. I'm at Arvape Medical Center.
Okay.
And
contact details?
Contact details are 011-922-1000.
Dr. Boule, I think this needs to be quite the regular thing. We need you on a regular basis. We didn't even get through half of the questions, but I think you've given us a lot to think about, and definitely for us to be able to be in tune with our own bodies and knowing, okay, is this normal or is this not as well? Thank you so much.
It's been my pleasure.
Absolutely.
This